Well, thank you for having me here. I'm just honored to be amongst all these giants. And thanks for coming to listen. So again, I'm from the University of South Alabama in the U.S. If you don't know where that is, and I do not have that accent, it's a very deep south. So we're on the Gulf Coast, down by Florida. I'm close to the beach. In our population, though, we're very fortunate. We have a very diverse population, and I'll show you some of our details. I'm trying to be careful which button not to push. Okay. All right, and here's my disclosures. I am reporting a study that was funded by Bruin, Biometrics, and that's pretty much it. Okay, so we're gonna, just quickly, I'll just highlight here, racial health disparities. That's what I'm all about right now because I'm in an area where I'm in the minority. Our population, African American, is now I think 52, 54%. So I'm fortunate. My practice though, I was born and raised down in Florida, South Florida, not so much, pretty Caucasian. I did most of my practice up in Indiana, again, pretty much Caucasian. I went to a prominent nursing school, and a few. I get a lot of alumni letters asking for money. And, you know, my nursing education, pretty much white, I'll just be honest. And nursing, our textbooks, and we're not going to talk about that. You could see that's one of my passions, but it makes a difference. We've been taught. I was even listening to one of the speakers this morning, and he talked about the dermatology apps and the photos. Did you notice on his slide how many, they were all white. So that's our norm. That's what we measure against. That's one of our challenges. So that's what we have to think about. And we talked about racial, I'm going to show you some racial disparities occur when we fail to adequately assess, identify, and prevent pressure injuries in people of color. So I want you to think about that. I won't go into too much detail. In the US, we talk about health equity a lot. Here's some graphic depictions. I think it's self-evident, so I want you to remember equity is not the same as equality. And I really want to emphasize that. HRSA, which in the US is Health Resource, anyway, I can't, Service Administration. Anyway, it's a government organization, and these are their definitions. The absence of disparities, or think about avoidable differences. And that's what we're talking about today, isn't it? We're talking about visual versus enhanced. So does that mean we have the opportunity to avoid some of the disparities that are happening right now? CDC, which is our Centers for Disease Control, talks about, you can see I've highlighted, eliminating preventable health disparities. That health disparity in our skin assessment, I want you to think about that as I present our study, because that's what we're trying to eliminate. So our study that we did, we wanted to look at the effectiveness, the feasibility, and the equity of using an enhanced skin assessment methodology using subepidermal moisture measurement to assess, identify, and prevent PIs in adult critical care. Our sample population was in the surgical trauma intensive care unit, so not cardiac. So we have trauma. We are a level 1 trauma hospital in the southern Gulf Coast area. So this is where all the trauma patients come. So pretty much we have a lot of gunshot wounds, we got a lot of car accidents, and you'll see my age mean. Here's our specific aims, and I'll present those more so you can look at them. Okay, here we go. So our design was retrospective. All right, and so that's just as good as it gets. I mean, it's not the best, but the reason we did retrospective is because we had the data. I'm in the university setting research, but a lot of my academic practice was in the clinical setting. So any of you guys, how many are in the clinical practice? Okay, so we got a lot of other people, researchers. I'll just tell you, it's hard to do research when you're doing clinical practice. Because when you're not paid to do research, you're paid to take care of patients. All right, I got to do my patients and then plus do a study. Okay, I see some head nods and laughing because it's doggone hard to do it in the clinical setting. So, knowing that, I also have a joint role at our university hospital. I talked him into doing a trial using the subepidermal moisture measurement device. Just like Dr. Cunningham, then COVID hit. So we've got all the devices there, and all of a sudden our clinical support from the company, we're not allowed to come in anymore. So we've got the devices, we've got our nurses trying to do it, and they are busy. They don't know what they're doing, and they're just using the device when we're telling them, please use this device. Okay, so I've got now, retrospective, I've got all this data of all I've got is a list of patients and their medical record number, and I've got all their SEM data. So I want to do something with that. I don't want to just lose this emphasis on doing a trial. Never give away your information for free. I'll just say that. Okay. I already told you about our sample. So this was a trauma unit. We collected a lot of data. So we took the MRNs and the SEM data that we had, and then we connected it to our purpose and aims, and you can see all the different data that we collected. So here's our results. We had 69 patients that we were able to use the SEM scores, Delta scores. Majority were male. You could see the race, we had a nice mix. And I will say this, I'm very conscious of terminology. In our medical records, the way we define race is by African American, white, Asian, other. Saying that, in the US, we use terms interchangeably. African American versus black versus people of color. I'm not sure I want to be very respectful of all races and colors. So please forgive me if I hope I'm not offending, but I will use the term African American. They're not all from Africa, I'll tell you that. These are African American, but that's the problem with terminology. Also, your African Americans are not all dark skinned. So keep that in mind when you're looking at this data. But for this study, that's what we were looking at, is the race. Ethnicity. Look at mortality. 18% died during this hospitalization. Now they're sick and they're trauma. They had a lot of things going on. Pressure injuries. 22% developed a pressure injury during this time. And of those, 40% were African American. You can see there was really not much difference between the African American and white. All right, so we then broke it up. Those that developed a pressure injury and those that did not. And I combined it here with they did not get one, or they came in with a POA, meaning present on admission. We're very conscious of that in the US. Again, forgive me, I don't mean to keep saying we over there, but I'm just not sure your practices over here in Europe. But so again, by pressure injury, you can see the differences. So again, there was a difference in gender. There was a significant difference in age. Those that were older did get a pressure injury. You could see smokers and vasopressors. So this is just our sample characteristics. And here, if you look, again, I looked at our pressure injuries, and here's just the breakdown. Now, with our SEM scores, our SEM delta scores, we did it of the 3 body locations. Throughout this study, I'm emphasizing on the sacral. So you can see that 57% had a SEM delta score that was over 0.6. meaning they're at risk, right? Here you can see by race, and here I will report by our aims. So we wanted to compare the SEM delta scores by race, and we broke it up here, hospital acquired, no they had none, or POA. And you can see of the hospital acquired, we had 4 with SEM delta scores. Now I will tell you, don't try to add this data up because we didn't get SEM deltas on everybody. So that's why it's a little bit off, but you can see this information. Among the 26 African American patients we did have SEM delta scores, 4 of them developed a hospital-acquired pressure injury. Of those 4, 3, or 75%, had a SEM delta score over 0.6. Here's just another way you can see it in a graph. Here's our aim 2. We wanted to look at the proportion of hospital-acquired pressure injuries compared with the SEM delta scores. And here you can see hospital-acquired. We had 9 subjects with 0.6 or greater, 82%, and you can see the other scores. Here you can see it broken down as to who developed a pressure injury. 82% that went on to develop a hospital-acquired pressure injury had a SEM delta of 0.6 or greater. Aim 3, we were looking to examine and compare pressure injury risk factors and the number of pressure injury prevention interventions across individuals according to their SEM. So the way we looked at pressure injury risk factors is the Braden, right? That's how we measure risk. So we were looking at those risk scores, and we do subscale scores too, but for this slide I'm showing you the total scores, and we did it, we used a tool that I had developed in previous work called the Pressure Ulcer Prevention Inventory, and that looked at avoidable versus unavoidable. Well, to fill out that tool, you have to do a Braden inventory that looks at the scores and looks at the number of interventions according to the subscale score. So, activity, mobility, sensory perception, and friction and shear, those pretty much are the same interventions, right? Move them, right? Elevate the heels. So anyway, if you look here, you can see that the Braden scores and the SEM delta scores make sense, don't they? So I'm going to let you just look at that and we'll move on. So here, again, aim 3 we're looking at. So like I said, using these other instruments, we determined when appropriate interventions were done or not. So you can see here, appropriate interventions were not documented. Remember, this is retrospective, on almost 64% of our patients. That's a problem, isn't it? That's a real problem. Now, I want to do a caveat here. Remember, our study was done in COVID, right? And I told you we didn't have clinical support, too much to support it. So our nurses did not use the SEM score. They were not instructed to use those SEM delta scores to drive interventions. All they were doing was getting score and then going about their work. So there was nothing additional to usual scores, to usual care. Okay, so of the 35 subjects that had a SEM delta score greater than 0.6, 62% did not have appropriate interventions documented. To me, that was such a red flag. If we had used the localized risk score or factors of the SEM, remember, that's the difference. And we've talked about that. So that's the difference of other risk assessment versus our SEM scores. We have a localized, we have a risk that targets where the problem is. So this just confirmed, and this agrees with previous work that we've done. And I think this tells you pretty much the same thing, except we looked at race. So of the 14 African American cases, 9, well, there you go. Okay. We also looked at satisfaction, and the nurses liked it. And they felt that it gave them a better, more accurate skin assessment tool for those with dark skin. So here's in conclusion. Important information that all of our studies are showing. We demonstrated the use of the SEM device in identifying the PI risk at specific locations. And I think that's a real takeaway that you can take back in practice. It also might help you address racial disparities. If your population has a lot of dark-skinned individuals, you need to think about, what am I doing in addition to my eyes? And I want to thank you so much